Good morning and welcome to Telebehavioral Health, working with courts and criminal justice. Thank you for joining this session today. I'm Dr. Michelle Carnes at the Health Resources and Services Administration, otherwise known as HRSA, in the Office for the Advancement of Telehealth. I am the program coordinator for the National and Regional Telehealth Resource Centers, of which Matrix is a part. I'm delighted to be moderating the session today, cast with very impressive people who are experts on this topic. We're going to hear about a wide range of subjects, including doing virtual competency assessments, virtual competency hearings, forensic examinations via telehealth, how telehealth has shortened wait times, and other wonderful things about it, as well as some of the challenges and limitations to using telehealth in this context. So before we get started, a few words about how the session will run. This will be a panel-style conversation with speakers first introducing themselves and giving some background on their expertise, and then a slide presentation with pauses for a deeper dive on various subjects along the way. So not only is this session a hybrid of in-person and virtual, it's a blend of scripted and unscripted. Speaker bios may be found in the virtual event platform. We will be taking questions at the end of the slide deck, and please use the Ask Questions during the Q&A box. Using the Q&A box in the virtual event platform. So at this time, I'll pass the mic to Dr. Sarah Edwards to introduce herself, followed by Dr. Evan Vitiello, Dr. Eric Weintraub, and then Dr. Edward Kaftarian, who will launch us into the slide deck presentation content. So Dr. Edwards, you may begin.
Thank you so much. Good morning, I'm Sarah Edwards. I'm a child psychiatrist at University of Maryland School of Medicine. There I serve as the director of the division and the medical director of our services at the medical center. We do have a children's hospital within our medical center, so we have a pretty robust amount of services, both acute care and throughout the community. And supposed to be able to advance. There we go. I don't have anything to disclose. There we go. So we're all keeping our brief presentations to a couple of slides here. And I think as a child psychiatrist, my colleagues here will be speaking about adult services. And today I'll be focusing on some of the work we do with the juvenile justice population. But I also feel a little bit of a need to make sure that we discuss the mental health crisis of our youth currently. So we know that prior to the pandemic, our kids have been suffering. Suicide is the second leading cause of death for kids ages 10 and older. And back in 2019, we knew that there was 13% of kids were diagnosed with major depressive disorder. But that might not sound like, oh, 13%, not that much, but that was up 60% from 2007. Kids are experiencing higher rates of depression, anxiety, and this was all prior to the pandemic. So then COVID rolls around and we take youth and we isolate them, we disrupt their schedules, they're not in schools. And so it just has compounded, our national crisis that we're seeing. So our Surgeon General back in December said, hey, everybody listen up here, let's put out the public advisory. It's just really important that we have that context when we're talking about trying to think of creative ways to increase access and treatment to youth. So general population, we already knew that 1 in 5 had a diagnosable mental health disorder, but the youth who are involved in juvenile justice have much higher rates. So as high as 70% have at least one, majority have 2 or 3 diagnosable mental health disorders. So we're treating an acute population that really needs services. And what we did was we were a little bit before the times. So at University of Maryland, our division has been doing telepsychiatry since about 2008, 2009. I do want to give a shout out to our previous division director and leader, Dr. David Pruitt, who was really a leader in telepsychiatry services. So we had started working with the Department of Juvenile Services in the Maryland area, and one of the on-site facilities closed. So they came to us and they said, we really like the work that you're doing, but how about coming and serving in Western Maryland? And how about at this youth camp across the state? So we knew there was no way that we were going to be able to provide on-site services driving several hours away. It's hard enough to kind of recruit and retain child psychiatrists in academic medicine. let alone driving around to underserved areas. And also treating a population that really has a lot of need. So in 2016, they decided, okay, they're willing to partner with us and we could try doing this telehealth version. So we had 4 different centers and we added one in 2017. So the data I'm going to describe is like a 2-year period between July of 2016 and June of 2018. And we did an extensive chart review and we were able to report on 209 youth. So these were kids between 13 and 19, average 16.2 years. This youth, the majority of them did not have a high school diploma or GED. 72% were Black, 19% white, 18% Latinx. Youth who had a lot of previous arrests and involvements, so 7.9 previous offense, and of that, 78% had a felony, and of that, 61% were charged with what we would consider or were classified as violent crimes. So lots of disruptive behaviors, offenses, and this is really disheartening that the average out-of-home placement's 12.6. So what that means is that these kids were in foster care or residential. And by the first time we're seeing them, they had already been on average 12.6 different placements. For parents in the room here, that's just unimaginable. So we looked at all their charts, and when we on the first meeting with them, their diagnoses, many different ranges. It's not going to surprise you that 72 met criteria for a substance-related disorder, 68% were conduct disorder, 60% ADHD, and 29% depression. So we were able to start seeing these kids via telehealth. Now back then there were these like huge TV equipment. I don't even remember the technology at the time that we were using, but it was innovative, and another shout out to our department of psychiatry IT department who were able to figure out how to do some of these connections. Over 80% of the youth, by the time we saw them, they came back for another appointment. So that helped to show that these kids did need treatment and that they were willing to engage in this manner. The rates differed. About 34% would have between 4 and 6 visits with a psychiatrist. And there was a small percentage, around 7%, that would have over 10 visits with our psychiatry team. Most youth are discharged. They might have another court appearance and the judge is like, okay, you can go back home. So that contributes to a lot of why some kids might have one appointment. Doesn't necessarily mean that it was completion of treatment, but a lot of times just some of those other factors. At the time when we were doing this study, we were looking at, is this feasibility and tolerability, and because it was very new, and high rates of patient, provider, staff satisfaction. So the staff really liked this. They liked being able to work collaboratively with continuous providers. Prior to our services, it used to take at best 4 weeks before they could see a child psychiatrist, but several times it would take months because some of these facilities are in the remote western part of the state, and they just never had the child psychiatry providers. And we were able to decrease that to days. So this was, again, prior to the pandemic and early on. And what I'd like to highlight, just looking at the one data point, sorry, if I can advance the slide, there we go, is that our psychiatrists were really able to, in doing a good assessment and looking at their initial diagnoses, and then when we went back to see after diagnoses, we see that our psychiatrists ended up there were increased rates of diagnosing these youth with trauma disorders, depressive disorders, and anxiety disorders. So that is identifying more of the internalizing rather than just focusing on the disruptive behaviors. And so I think that's so important as we're considering how to best treat these youth that are at risk and making sure that we're treating the right thing with the right treatment. And so happy to further discuss a lot of the work that we've done in telepsychiatry. And with that, I'll just kind of close with those data points, and I can answer some questions now, or Michelle, would you like everybody to do their couple of slides and then we'll come back?
I think that works. Let's have everybody introduce themselves and we pause for questions before we go into the mix.
Can people hear me online if I stand here so I can kind of look out and see folks who are here in person? Can you hear me, Michelle, okay?
Yes, you sound good.
We hear you.
Great. I'm Evan Vitello. I am an assistant professor at the University of North Carolina School of Medicine. I'm a forensic psychiatrist. I have no disclosure. So I was asked to speak about civil commitment and telehearings related to civil commitment. I know that probably many people who are in this meeting, either in person or virtual, are likely in behavioral health and know something about civil commitment. But for those who are not, they'll get just a little bit of background. So we're talking about civil commitment or involuntary commitment. We're thinking of a legal mechanism by which we can detain essentially individuals with mental illness who are dangerous. This is statutorily defined by state. It differs state by state, though is largely similar in the sense that we're looking at someone with mental illness who is deemed to be at danger of risk to their self or to others. Over the years, this has largely moved away from this need for treatment to this confinement of dangerous individuals. And the Supreme Court has heard numerous cases regarding civil commitment through which they've outlined various legal protections that need to be inherent in those cases. And so the Supreme Court is saying that, these are individuals who are detained suffer a massive curtailment of liberty. And because of that, they require various due process protections. And I'll talk a little bit about why these due process protections are important when it comes to telehearings. So some cases, these are in the 70s, Lassard v. Schmidt. This is when we focus more on dangerousness. Addington v. Texas, we raised the standard from a preponderance of evidence, which is likely seen in most civil cases, to clear and convincing, so an intermediate burden of evidence in these cases, which again is meant to outline that these are curtailments of liberty that need due process protections. Through these cases, we look at, this is an adversarial process through which, a defendant, or the patient is now called a defendant, and they're placed at trial, and they're kind of going against the state who's bringing their case against them. So rather than what we view as, a treating relationship, this is now an adversarial setting. And through these kind of protections in the civil commitment process, we've seen this criminalization of the process. So what I mean by criminalization is that people have, a counsel, right to, effective assistance of counsel, to speak with their attorney confidentially, things like that we don't really think about in day-to-day treatment settings. So I'll focus a little bit first on in-person hearings, as then we can transition to thinking about what telehearings look like for civil commitment. So the first thing that people think about when it comes to in-person hearings is, again, many states do this differently, but some may have the defendant, the patient here, transported. And so how do we transport people who have mental illness and who might be dangerous? We do that through police and in handcuffs. And so some people think initially of the dignity of our patients who are here now in handcuffs, who think, what's going on? Why am I being charged with something? Why am I going to a courthouse? Did I do something wrong? Am I going to jail? Right? These are all questions that likely someone who's being placed in handcuffs in the back of the cop car have racing through their head. The next thing we think about is elopement, right? So now we're transporting these people off of a locked unit that likely has different safety mechanisms through double locked doors. Now they're being taken off site. They might be going to a courthouse. There's an increased risk that throughout this process they could elope or leave in some setting and that outcome. When we think about people who are dangerous, some people think about agitation, and this agitation is now in an uncontrolled environment, right? The court isn't set up to deal with someone who is behaviorally dysregulated or behaving in dangerous ways. An inpatient psychiatry unit is more so equipped to handle that kind of situation. Staff presence. So now, in some places we're pulling staff from their duties on the inpatient unit to accompany the patient. So nursing, one-to-ones, hospital police officers may be forced to accompany the patient and no longer doing their duties that they either signed up for typically. The next thing we think about is space constraints. So either this is a courthouse or a conference room, perhaps at a hospital and inpatient facility. When can that space be used? How frequently can it be used? Are places having hearings every day, every week? How frequently do they have to have those hearings? And depending on that, how much access to space do they have to accommodate that? As I turn to the psychiatrist role, the clinician role, thinking about removing someone from their clinical duty, right? So now instead of treating patients, I may be on an inpatient unit with a number of patients who need me or need to speak with me. Now I'm being removed from that. I'm taken either to a courthouse, I'm taken to a conference room, I'm removed from the unit. I'm not typically available to handle a few things that come up on the unit. And so that removal of duty is another thing that people think about when it comes to in-person hearings. And then returning to the unit is the last thing I want to spend a little bit of time to focus on. This is one of my interests, is that I don't know how many people here have testified at a civil commitment hearing, but it's generally an awkward position to be put in, right? Like, this is the dual agency that most psychiatrists try to avoid. We don't want to be a treater as well as testifying against the patients that we're treating. And so now I'm there sitting across from the patient saying all these things about their mental illness, about how they're dangerous. I may be reciting quotes that they've said that support the evidence that I'm bringing forward to the court. I say all these things and the patient's sitting right across from me, and then we go back upstairs if they are ordered for commitment, and I have to continue to work with that patient and collaborate in some way and have the patient buy into me not being a bad person in their life or someone who goes in front of the judge saying bad things. And we think about therapeutic alliance or rapport as an important aspect of our treating relationship with the patient. And this is generally thought to be damaging, right? When someone's being a dual agent to the court and to the patient. So when we think about telehearings, I'll show you what the North Carolina statute is. I happen to practice in North Carolina, but it's also nice that we're in North Carolina now, I guess. But this slide is mainly intended to show that people from every state have their own statute when it comes to civil commitment hearings. In North Carolina, they have to have a district hearing within 10 days. Again, this is the second bullet point is mentioning the criminalization of the process. There's this right to confront, cross-examine witnesses. You as a psychiatrist are here viewed as the witness, so the patient, the defendant, has a right to confront you, to cross-examine you through their special counsel. In North Carolina, there's a hearing in a conference room at the facility where they're being treated at, so they're not transported off site to a courthouse, but they are transported off the unit to a conference room. And the statute outlines that these hearings can be held by audiovisual transmission only if it allows the judge and the respondent, the patient, to see and hear each other. If the respondent, the patient, can communicate fully and confidentially with their counsel, and the respondent has the right to object to a virtual hearing. And so at UNC, what we did is have all parties separate when it comes to a telehearing. Different states do this differently. Telehearings have been going on for over 20 years. There's cases from the 90s in federal court regarding telecommitment hearings. And so what we did is that judge, doctor, patient, counselors are all separate in different rooms and all connected to a secure WebEx link, essentially, is what it is. Some states will have the court personnel located back at the courthouse and all the hospital personnel, like the doctor, the patient, to be in a separate room in the hospital with the hearing. For us, what we think about when it comes to civil commitment and patient confidentiality is one thing we think about. So, these are closed hearings; they're not open hearings to the public. So you have to be sure that people, most people think about Zoom bombing or something like that. What I more think about is like who is sitting in with the patient to ensure they're safe, right? So you don't want someone who's sitting in who's then going to hear all these things about their mental illness and then have no sort of duty to confine that information to just themselves. So we have hospital police staff accompany the patient in that kind of room where the individual is located. The reason being is that we typically don't allow patients to have unfiltered access to computers, to the internet, and so how do you secure that kind of technology in a way that they can't do something harmful or use that in a bad way, essentially. And so there is a hospital police officer who stays with them through the hearing to ensure that it's a safe process. I did a forensic fellowship this last year that was entirely virtual, and so I can talk more about sort of competency to stand trial evaluations if people are interested in that. But I'll pause here from the civil commitment side and move on to Eric.
Thanks, Tim.
Yes.
Morning, everyone. I'm also from the University of Maryland. I'm Eric Weintraub. I'm a general psychiatrist, but over the last few years, I've specialized in addiction, like 20 years actually. And I've worked a lot with individuals with opioid use disorder. Baltimore has a high rate of opioid use disorder. The last, probably now 7 years, we've gotten into the space of trying to provide access to medications for opioid use disorder to underserved rural areas. We've been using different telemedicine, kind of evolved over time, using different models. More recently, we saw that our patients tend to go from emergency rooms, hospitals, to outpatient clinics, to jail, and maybe we would see their treatment get disrupted. So we wanted to try to work within the jail setting. And I'm going to just talk a little bit about the work that we're doing there. I don't have any financial relationships or conflicts of interest to talk about. So incarcerated individuals have a heightened risk of opioid use disorder and overdose. And here are some of the numbers that are actually pretty staggering. Kind of talk about or tell us kind of why we have so many people incarcerated in this country. Rather than referring people for treatment, we lock them up. Many of the patients that we do lock up with substance use related criminal activity are really just good people that are out there trying to get money to support their habit. There's high rates of death upon release involving overdose death, and first 2 weeks of release are specifically very difficult for many patients because they come out of jail, they have no tolerance to any opioids. They've been detoxified while in jail, medically withdrawn, I think is the term we're using now. They have no tolerance, they go back out and use. And for those, most of us know that the drug supply is really dangerous right now with synthetic fentanyls. They're highly lethal, go out and use, and it's hard to know what's in the drugs and how much to use. They don't have tolerance, and you see really enormously high rates of overdose deaths in that period of time. You can see it kind of levels off after this first couple of weeks. Just real quickly, we got into space in 2015, and our model is to provide medications for opioid use disorder, specifically buprenorphine. We can't do methadone. It's highly regulated. It has to be delivered through an opioid treatment program. We can do naltrexone and Vivitrol as well. But what we've done is we've worked with pre-existing treatment programs. So we're not, Maryland's a little different than Alaska. It's like rural, it's not rural. It's same type of rural. In Maryland, if you're rural, you're within a half hour of a pharmacy and within 30 to 45 minutes of a treatment program. So we decided to focus on pre-existing treatment programs that didn't have access to individuals that could provide buprenorphine. You need a waiver to provide buprenorphine in certain areas. There just were no physicians or providers. So we started with treatment centers, and we started working with health departments. When we got into the health departments, the band there, we found that even in working in a small county that had a health department delivering telemedicine services, many people couldn't get to the health department. So we actually put a program with a van, got a grant, put a treatment team on the van, and we go to small towns and we provide we do clinics in small towns. And then one of us in Baltimore is providing the medication-based treatment, but we have a peer recovery specialist and a nurse and a counselor on the van to provide other services. So anyway, we got a grant from the Ford Foundation to try to expand this work into the county jails. So what I was seeing was I would see patients come on the van, that were doing quite well or in one of our treatment programs, stable, hadn't been used any kind of illicit drugs in all 6 months, getting their lives together. Then they would get violated or on charge, violation of probation, go to jail, they're taken off the medicines, they go to withdrawal, they come out, it just totally disruptive to their lives. So at least we felt like we could continue that in treatment while they were in jail. So we got a grant to try to do this in 3 different jails. And the bottom line was the implementation has been challenging for many jails. So you're dealing with law enforcement and different wardens. And so let me just take a step back. So you had to deal with the warden and the jail staff, correctional officers. You also had to deal with the medical team, which usually is contracted out. And then in Maryland, you have to deal with the health department too, because a lot of the funding has to come through the health department. The state will not fund us directly. So to have all those partners aligned was a lot more difficult than I had anticipated. And but we were able to get into 3 jails, and I could go through a whole in a question and answer if people are interested, talk about the difficulties implementation. But we finally found the perfect jail. It's in Allegheny County, it's Western Maryland, and they have a very enlightened warden, sheriff, who really believes that the people that he takes care of, he's taking care of his prisoners. And it's not just about punishment, it's like his family. And he was pro implementation. We got a great medical team there, a great health department. So all the stars aligned. And we started treating patients there about 8 months ago. And these numbers are sort of old, but we've treated approximately 120 patients, unique individuals, in a jail that has a census of about 180 individuals. So there's lots of people with opioid use disorder that are being incarcerated. And again, it's been a whole process of the implementation, developing standard operating procedures that work. But one of the things, and I'm going to try to go through this quickly, was just to see are people showing up after we treat them, because people want to get treatment in jail. It's not a whole lot to do in jail. And the other thing to tell you is in this jail, they have an intensive outpatient program as well. So they were able to get counseling in addition to medications. And what would happen is I set up shop in Baltimore. We have great IT team set up special computers or screens where we can do video conferencing. We were able to schedule them in our electronic medical record, prescribing. Here we're not using the pharmacies, but we do orders with jail nurses, and we're able to bridge patients when they leave until they can get into an appointment with a provider. But what we're able to see is about that 59 out of our 80 patients, initial 80 patients that we treated, did continue in care. And then we were able to look at things a little bit more specifically in this next slide. When people left, like I said, a lot of them needed bridge prescriptions because they wouldn't be able to get an appointment for 3, 4, 5 days. We have a system in Maryland called CRISP where we can actually look at which prescriptions have been filled. And we went back and looked at those, and we found that 40 out of our 48 patients that we wrote bridge prescriptions actually filled that first prescription. We're still looking at the data to determine how long people actually stayed in care, but we felt that was an extremely positive sign. We see all sorts of patients that are on medicines when they come in, patients that have never been on medicines, and we have a psychiatrist, addiction psychiatrist, do a full evaluation and make a determination if the person needs to be on medications and what type. And the other thing, this has become a very interesting experience for trainees. Things have shifted. When I was training, nobody was interested in individuals with opioid use disorder. Now people are. I think there's a variety of reasons for that we can talk about. So people are interested in helping and working with this patient population. We had a really high turnout. The other thing that we did is we're looking at a little bit, we were looking at acceptability among staff, what they felt about the program, and there were some pretty interesting outcomes. So acceptability, buying support is critical. fast. I don't have this slide. So they're gone. But basically, there's this graph, and the administrative team and the medical team like the program, and then when they answer the correctional officers, the graph went down to like 0. They said, this is a waste of time. And I've had those discussions with some of the correctional officers as we've developed relationships, and I just feel like we're giving people drugs while they're in jail. And jail is more for punishment than for treatment, and there's a lot of stigma, a lot of work to be done as we kind of roll this out in different. I think this is something that's being done around the country, and hopefully everybody will get an opportunity to get treatment so they don't have to go back in jail. So anyway, I'll turn it over to Ed.
Thank you, Eric. So my name is Ed Kafterian, and I'm the CEO of Orbit Health Telepsychiatry, which is a company that provides telepsychiatry services to correctional facilities as well as community mental health. I don't have any conflicts to disclose for this presentation, but I do, want to say that I'm the CEO of this company that does provide correctional care. So I don't think it's a conflict because I'm not promoting any goods or services for this talk. So I'd like to tell you a little bit about myself. So I'm a forensic psychiatrist, and I spent my entire career in corrections. And I developed with my team, developed the telepsychiatry program for the California state prison system. And I want to tell you kind of how that happened. So around 2008, 2009, I was doing a special assignment at headquarters in California in Sacramento. And I came across this room where I was being given an orientation to the headquarters facility. And they said, oh, by the way, this is telepsychiatrist. So there were 3 psychiatrists there serving 2 prisons, and they were raving about telepsychiatry. So this is quite a while ago, and they were saying, yeah, we can't believe that this is not being done more often, because I really enjoy not having to go inside of a jail or a prison. I just come to this office, and it's safe, and it's pleasant, and it's clean, and I see my patients, and I go home. And so a little light bulb went off in my head, and I thought, well, yeah, what they're saying is true, and we've had difficulty recruiting. So at the time, I was working in the Bay Area for San Quentin State Prison, and we had no difficulties recruiting there, but we had a lot of difficulties recruiting in the Central Valley of California. And so, for whatever reason, psychiatrists like to live in urban areas and with access to amenities and restaurants and all that kind of stuff. So I made a proposal to the headquarters saying, hey, why don't you let me expand this program and we can solve our recruitment problems. And I was fully expecting them to say no, as they typically do in bureaucracies. They just say no, and sometimes they give us a reason, and sometimes they don't. But miraculously, I was given the green light on that, and just started rolling. And so we were able to develop the telepsychiatry program out to almost every facility. I think there was only one facility that was not covered by the time I left to start my own company. So we know the advantages already. This is a slide that I used years ago to convince people why telepsychiatry works for corrections and in general. So of course we know that doctors can avoid traffic. It's a comfortable environment. It allows us to strategically deploy providers. So these are all reasons that you're well familiar with at this point. The provider can span geography. So I can serve a jail in California in the morning and one in Texas in the afternoon. I have a Texas license as well. So that gives me the opportunity to see patients in all kinds of facilities. We can leverage time zones. It avoids unnecessary transport, which is huge in corrections, and it saves costs, and the patients like it. lot of the data that's come out shows that as previous presenters on this panel have shown, provider satisfaction, staff satisfaction, and patient satisfaction. So thank God for COVID. Okay, so COVID is obviously really problematic for many reasons, but and it did have a huge impact disproportionately on the jails and prisons in this country. And this slide needs to be updated, but at the time, about a year ago, 160,000 inmates had been infected. And there was a huge crisis in California where they were shutting down transports to San Quentin because there was such a high infection rate. And just everything got shut down, and then telepsychiatry kicked in. This is across the nation. And it really saved services. Okay, and so let me move forward. So I say thank God for COVID, and I'm being sarcastic, but there's an element of truth here. I think that COVID really got the late majority in this adoption of innovation curve where you have innovators, people who've created this technology, to the early adopters. Think of, were you the first one in line for the iPhone when it came out in 2007? I wasn't the first. I waited a month or two. So I don't know, maybe I'm an early adopter. And we had the early majority over the last few years, well, prior to COVID, that started to really understand the benefits of this technology. And so finally, COVID was an inflection point, and it tipped the scale there. And now everybody does appreciate the benefits of telemedicine. And in fact, let me tell you that this is a hard sell, and I feel good about the fact that I was trying to sell it for the pandemic, and some people believed in it and some didn't. And I recall specifically UC Irvine. I spoke all over the state about telehealth and the adoption of it. And about, 5-7 years ago, I went to UC Irvine to give a talk, and brilliant people there, really great institution. And I got so much resistance over telehealth, and everyone was saying, "Oh, isn't it better to be in person? Because you lose with telehealth, you lose that sort of dynamic relationship and interaction that you have with patients, which is so important in diagnosing and treating people." And my response was, well, it's not, it's a false comparison, because you're comparing on-site to telehealth. First of all, I can tell you that telehealth is very effective. Secondly, it's the wrong comparison, because you're comparing it to in person. I'm comparing it to nothing. So it's, that's the comparison. Do you want telehealth or do you want nothing? And so that was my pitch. So why has correctional telepsychiatry worked? Well, the jails and prisons are a dirty and noisy environment. It's uncomfortable, and it's just not a setting that a lot of people can thrive in. I mean, I don't mind it, and certain jails are much cleaner and nicer than others. But this is a place where people suffer, and you kind of hear the suffering, you feel it, and to be in that environment is hard for some people. And so when you're in telepsychiatry, you're removed from that environment, so it's just naturally more comfortable, and it's easier to get through the day in the caseload. Something that people often don't think about is that the jails and prisons often have an authoritarian culture to them, where it's command and control. And they were designed to basically inflict punishment and pain. And thankfully, our society has moved away from that somewhat, not fully, but we understand now that the punishment is the time that the inmate spends in the jail or prison. It's not, you don't go there for extra punishment. Like our job as providers well, let me say, the job of the custody officer is not to inflict more pain than punishment. The job is just to ensure safety and security. And I think that largely I've seen a change in the attitudes of custody officers where they seem really a lot more sympathetic to mental health concerns and medical concerns than they used to be. But there are still some that think of us as care bears and hug-a-thugs and whatever. When we try to help our patients, and especially with substance use treatment and other treatment, they think of it as like, why do these people deserve any kind of treatment? They should just suffer. And so that culture sometimes can create an environment where the provider themselves feel like they need to toe the line on that. And it's, a lot of people would say, well, I wouldn't be like that. I know, and I would make sure that I keep my hat on as a treatment provider, but you get sucked in. Let me tell you, when I first started at St. Quentin years ago, the first thing you feel when you walk in there, it's a beautiful place, but you walk in there and the first thing is the sally port, it's big metal bars that like boom open and then boom shut, and then you enter into the prison yard. And then what I did when I walked in was I went to kind of find where I was going, and I didn't know quite where to go. And you could hear alarms go off. It kind of felt like a Hollywood movie, like Shawshank Redemption, where they come in on the bus and then you see everybody staring at you. And so I remember walking through a crowd of inmates. They were all dressed in orange, and sort of like, as I was walking, they sort of parted a little bit to let me through, but I could still feel the presence and the weight of their stare. And I remember somebody made fun of my suit, and I didn't even know what to do. I kind of turned around and felt like I had to defend myself, which was the wrong thing to do. But anyway, they gave me a stab-proof vest. And I was like, wait, so nobody said I was going to get stabbed. And I started thinking, well, how many people get stabbed? And shouldn't it be a bulletproof vest? So, and then they gave me an alarm with one button, and they said, okay, press this if you're in trouble. And it's like, okay, well, I don't know if I want to work here. So then don't get me started with death row. I mean, that's a whole other thing. I worked on death row for a while, and that you feel this authoritarian culture where you feel like you're under attack, like you're going to war. And with telepsychiatry, you don't feel that. And, fortunately, I found a way to really find my niche in corrections, even on site. I worked on site for many years and I enjoyed it, but not everybody does. And I think that the authoritarian culture pervades your sense of how you interact with your patient, inmate patient, whichever one, comes first in your mind. And so with telehealth, you don't even think about that, honestly. Like you forget quickly that they're in a correctional environment. And I imagine if I was starting off with telehealth and corrections, that none of that would have applied to me, that feeling of, having to defend myself and these are the enemy, this is the enemy. I never felt that way, but subconsciously you might. Another advantage of correctional is that, typically when we're on site, we get in the way of custody. Custody, again, are for the purpose of creating an environment that's safe and secure, and we're just another body they have to worry about. We're little baby ducks that they have to protect against the wolves, And so it's just a lot of energy, it's a lot of money, it's a lot of attention. They don't want to do it. Most of the time, they don't want to have to worry about us. And so generally they do a good job of taking care of us, but it is a lot of energy. And so, working remotely, I think that we still need to be taken care of in some ways, but not from a safety standpoint. So, I talked about the advantages of time zones, taking advantage of that. So this made night shift possible. And I remember when we created the concept of the night shift with telehealth, it was a huge boon to all the on-site doctors who did not want to go and sleep in a cot. We've all, providers, psychiatrists have all had experience in med school and residency and in our careers of taking call on really uncomfortable plastic cots. And so this really made it possible for us to be within the comfort of our own home. And we would take the shift for the entire state, basically, or at least a huge part of the state. One person would take that. So it saved money that way. And we talked a little bit about transport. Evan spoke about that. So, transport is costly, and it also includes risk. So people escape, and you don't want that in your community, a runaway felon. So doing telehealth really does provide that safe way of providing care. So 70% of the prisons are in rural America, so that really does speak to the benefit of having telehealth for correctional. It's a fast-growing concept. Bypassing gates and elevators. So when I was working at the LA County Jail, I remember it would take me. There were 4 elevators in the women's facility, and 3 of them were broken. So I remember waiting for sometimes a half an hour for an elevator, and then going through all the gates and things. So it takes time. So let's talk a little bit about the challenges and the opportunities. So telepsychiatry can be observed as outsiders, we can feel like outsiders sometimes, where we're not really fully connected with the facility. When you're working on site, the process the fact that you're there, you get to experience the ups and downs and the current events and what happens within the facility. When you're remote, you see none of that. You don't really see when the yard is shut down, when there's a riot, or when patients are in trouble. You don't necessarily see it. You have to be told. And I recall when I was doing on-site care, I remember seeing this striking example of an inmate presenting differently, a patient presenting differently. And so he presented really depressed. He had his head down. He was like, "Yeah, doc, I don't know if life is worth living, blah, blah, blah." And he endorsed all the signs of clinical depression. And then just mere hours later, I was walking home back to go home. So I was going through the unit, and I saw him. He was talking to other inmates. He was really cheerful. It's like talking "Yeah, no, I'm just living the life, everything's great, whatever." He didn't really say those words, but it just kind of came across as this guy was really cheerful and happy. And so that's just one piece of the puzzle, right? I'm not saying that he's not clinically depressed, but it did definitely make me question his behavior earlier. And so when you are not on site, you might miss some of those things. So working with custody staff is definitely a challenge and also an opportunity. I think that on site, you can develop some close relationships with custody officers, but remotely, it's really hard to do. I mean, that's just all, straight truth there. I mean, when I was working on site, I would always connect with custody officers over football and other things, and so they would open doors for me because they knew me and they interacted with me. I even gave them candy every day. So I really tried to smooth the wheels, grease the wheels there, and you can't really do that with telehealth. But that's one disadvantage. And then let's talk about future integration. My last slide here: future innovations of telehealth and corrections. I imagine a situation where we can have cameras in the cell. I mean, I don't know, maybe some people might have a problem with that as far as civil rights kind of issues, but you can have artificial intelligence also that can identify, with cameras, certain patterns of behavior that can lead to suicide. For example, typically when an inmate is about to commit suicide, they may exhibit certain patterns of behavior, like they may pace around the cell. It's going to be different. What their behavior is going to be different than what it is when they're not about to kill themselves. Maybe their heart rate is going to go up, their breathing is going to go up. You have all sorts of physiological and behavioral signs, and I think with artificial intelligence and machine learning, we're going to get to the point at which we can identify these behaviors and send somebody to the cell immediately. It might be able to identify, a noose in the room through technology. So I think that, it's not just about telehealth. I think, telepsychiatry, it's also about telehealth broadly, that I think that it has a role in corrections. So and also one other thing about artificial intelligence and machine learning is that there's not a lot of discussion about olfactory. So with artificial intelligence, it's about audio and video, but I think that olfactory, the organic particles that go into the air when somebody is disheveled and malodorous, I think that is going to be part of the future. It might take 10, 20, 30 years for that technology to really develop, but I think it's going to be really interesting when we have kind of like a heat map that we look on our computer and see hot zones or where people might be suffering or doing poorly and maybe gravely disabled, and we can send resources to that. So I think there's all kinds of, this is a fodder for a whole other talk, but I think it's important to know that there's more technologies coming. So thank you very much. And now I think we're done with the slide portion of it, and we have some time to take some questions from the audience.
Awesome, thank you. For questions in the room, if the speakers would please repeat or summarize the question so that folks online can make sure that we can hear it. And then for folks online, if you would be willing to enter your questions into the chat, and I'll be happy to read those for our panelists. So let's start with folks in the room. What questions do you have for our panel?
How common is suicide in jails and prisons?
So the question was, how common is suicide in jails and prisons? I think that suicide, I'll take a crack at it, and then others can also take a crack. Suicide has gone up in this country during the pandemic, and in children and also in adults. And the suicide rate is higher in prisons, but it's mostly higher in jails, because jails are where you most acutely have mental health conditions present themselves. And oftentimes when people are in jail, they had just been arrested, moments ago, days ago, and they think, oh my God, my life is over, especially juveniles. When they get arrested, it's like they can't think beyond that moment, and they think my life is completely over. And so the jail, I can't quote you the exact numbers, but I can tell you that it's very high in jails and higher than the population. I think suicides in the general population now is maybe 50,000 suicides a year, something like that. Is that correct?
That's correct.
Yeah, and so that's a rare phenomenon if you look at it from a statistical standpoint. In a country of 330 million people, 50,000 deaths is still rare, so it's still hard to predict, but it is a problem, especially, as you said, in juveniles. Did anyone else want to comment on that?
And there is one statistic I read recently that sudden death in jails usually occurs within the first or second day, and I think that included suicide. So kind of in corroboration with what you were saying, you see a lot of people, whether it's gets to go to the jails, whether it's a medical issue, an intoxication issue, or suicide, it happens quickly before the health team can get to the individual, before anything's identified.
And do you think part of that is because we don't know the patient? We don't know what their chronic conditions are, that we don't know what their vulnerabilities are because they just got to us? Do you think that's part of it?
I do. Although I think a lot of the jails are trying to screen individuals when they come in. So I don't know how, I think it's hard to talk about this as a homogeneous situation because each jail and prison system is different. And it's run differently and the medical care available is different. So I don't know what.
Yeah, I mean, the screening aspect is probably the most important thing to consider. All jails have some sort of, all correctional facilities have some sort of screening process they have to do. And suicide is one of those things they have to screen for because in jail is such a high rate relative to the general population. As others have said, jail is most common earlier in their sentence because you can think about the other psychological factors that come into you've just been arrested, you're now confined. Prisons are a little bit different entities, right? People can be there for a long period of time. And so sort of the suicide rate in prison actually fluctuates over time in the sentence and different stressors along the way, like, you know, if they were denied parole, essentially, like that's an increased risk for suicide. If someone's found guilty but awaiting sentence and they're actually sentenced to a long-term sentence, that's another time when people can see the increased risk of suicide. So jails you see temporarily more in the beginning, and suicide in prisons is more fluctuating. It was initially thought it was just early at both, but prisons you can see it's still later on in their sentence. So we think about screening, but then we kind of lose the rescreening aspect, right? Like we don't think of policies or procedures to screen people in prisons, you know, when they're denied parole, for instance, right? But that's another acute time that we should think about rescreening.
It might, that's a great answer. And I was wondering if it might be helpful for the audience to know the difference between jail and prison briefly. So jail is where you go after you've been arrested and it's pre-adjudication prior to the judge, you know, weighing in and sentencing. It's usually 1 to 2 years. And then prison is where you go when, you know, it's post adjudication and you already know, how many years you're going to spend. And so there's less uncertainty with prison. Now it does select for a little bit more hardcore criminals, whereas the jails select for, you know, homeless people with drug addictions. And so, you know, having MAT programs in jail, I think even, you know, with telehealth too involved, I think it's, wouldn't you say that's like, it's a good use of resources to do that?
I mean, I think, and I have not spent as much time in the prisons and jails as you have, but if you look at how many people we have incarcerated in our country compared to the rest of the world, many of those numbers in top of your head, it's unbelievably weighted that we're much more likely to incarcerate individuals. I think a lot of it's related to incarcerating people with drug and alcohol and mental health problems rather than getting them into treatment.
I was just going to say that the juvenile equivalent, we have detention centers and then we have committed and non-committed facilities. So every state's going to be a little bit different, but in Maryland, we're currently in every type of facility. So there's youth camps, committed facilities, and then detention centers. So kind of the equivalent continuum from prisons, from jails to prisons.
Have you, Sarah, if I can ask you, we're trying to make this conversational.
Yes.
Have you found certain points in the juvenile detention process where they're more vulnerable, or more or less vulnerable, like things happening in their lives, or, you know?
I think similar points regarding if you're just entering the system, but as the statistics that I showed you, most of these youth, unfortunately, have had such challenging lives and circumstances that have brought them there. So, 12 out-of-home placements by the time that we are seeing them. And so they have chronic high risks, lots of family history of substance use and mental health issues. They themselves, 70%, having such extensive mental health histories. And so, I don't think there's been any studies to say for youth who died by suicide in juvenile justice services, these are the timelines, but it makes sense that those stressors that you speak about before or after receiving kind of that commitment from the judge. And luckily, though, our country as a whole has moved away from it being more of a punitive system than truly it is for youth trying to do rehabilitation. So again, depending on the state that you're in, things definitely vary. I don't know what the California youth landscape is like.
Yeah, it's improving. It's still horrifying to think that we would put a minor in jail behind bars and walk away, right? Do you feel like, I'll put it back on you and say, feel, how much improvement has there been? And do you think we still have a ways to go, or are we pretty much, yeah, okay.
Oh, we have a long way to go, because hopefully none of these kids will ever get there, right? So hopefully they wouldn't have 12 out-of-home placements prior to being with a peer group or, doing high-risk impulsive behaviors that led to the circumstances in which they're being in detention. So, I'm a big proponent of early childhood mental health and really going upstream and preventing youth incarceration. And then, of course, later, what you guys are dealing with adult incarceration, and hopefully preventing the substance use, like having kids learn self-regulatory skills and feelings identification. And so gaining those coping skills to be able to manage typical adolescence and the stressors. But these kids are coming from environments that are so much harder. Just a lot. We have to get upstream though. We have to make a difference with the social determinants of health.
And I wonder if telehealth can help with that, because with the prison environment is so toxic and so traumatic. People go there to get traumatized, basically. So I wonder if home detention or other ways of detaining, if detention is necessary, and with telehealth treatment, so you don't have to move these kids into those horrible environments. I mean, I visited juvenile facilities, and I think I would never want to experience that. And there are some countries, like I think in like Norway, Scandinavian countries and other countries, where it doesn't even feel like prison for adults, much less kids. I mean, they wouldn't even dare, detain kids, but for adults, you go there and it feels a lot better. So should we take another question?
That would be great. Michelle, do you have any questions in the chat for us?
There aren't any chats right now, and certainly we're happy to take additional ones in the room. But I'm recalling our prep session where we talked about establishing rapport with folks over telehealth and some of the techniques that you use, given that you're different than the system that they're part of. And I wonder if you could comment on that.
Yeah, I can start when it comes to, I was interested in establishing and perhaps maintaining rapport when it comes to civil commitment hearings. As in our kind of brief talks, I alluded to the fact that you're testifying against someone and then you return to the unit to then engage in a treating relationship with them. And there's some research that shows that individuals with psychotic illnesses view that distance as in some ways protective, that they're not kind of faced with you across from them in this intimidating or aggressive way that they may view it as. And so by allowing this sort of separation and space that telepsychiatry or telehealth allows for, that we can hopefully preserve more of that therapeutic relationship when we return back to the unit. They see you on a screen testifying versus they see you across the table testifying. And I think that is a big difference when it comes to how the patient, the defendant, views you as a person in their life. And so that was sort of one way that I was interested in. I had the personal experience of having to go back and talk with the patient, like, how did that go? I said some things, and I would often warn them before the hearing to let them know that those things would likely be said in the courtroom. But then, now that there's the space between it that telehealth allows, I think it allows for a different perspective from the patient standpoint.
Do you think that there's anything lost with the video link when you're doing hearings like that and testifying?
I think one of the big things that's lost is perhaps a way to provide support to the patient during the hearing itself. And I'll give you an example. There was a patient who clearly did not understand really the purpose of a commitment hearing, why he was in front of the judge, why there were two attorneys in the room. And when he was offered the chance to speak, he essentially asked the opposing counsel, the state's counsel, what is the purpose of this? Like, why are we here? And the opposing counsel said to the judge, I don't usually answer these kinds of questions, but is it okay if I do? And the judge allowed it. And so it allowed for, a scenario in which I don't think telepsychiatry would really offer, if someone was clearly confused on a video, I don't think opposing counsel would try to explain the whole process to them. And the hearing would likely have ended at that point, and the patient would return to the unit. Maybe more explanation would occur at that time. But I think perhaps we're losing some of the support that can be had in a conference room, everyone's sitting around the same table. That's kind of the main thing that I would think about being lost in that scenario.
I think it's really important as a society around telehealth to shift from pushing telehealth in all situations and promoting it in all situations to now examining it. I was a huge advocate for telehealth, and I still am, but now we're getting to the point in which the late majority has accepted it. And so now we really have to study the data. We really have to examine, well, in what situations are more important, because we don't have to convince people anymore. So I think it's important that we do acknowledge it. I appreciate that.
Yeah, I was going to go back to the original question. I think for me, with my patient population, I try to see them kind of in a continuum. They're not just there incarcerated in a jail, but a lot of these individuals I may have seen, not a lot, some I've seen in other settings. And I know they're going to be leaving. So I'm working in the jails, not the prisons. And this is kind of a blip in their course. So I try to have a more longitudinal view of my relationship with them. And the other thing is I tend to try to use the people on the ground to help me with what I can't see in the tele, because it is a little bit different. I've had patients I've seen only through telemedicine show up at my clinic, and it's like, hey, so, we get the nurses and the teams that we have in the jails and even other places. What does the guy look like today? They medicate them every day, and get some sort of feedback from them to make sure it's not quite the same, but get as much additional information I can to help make the right clinical decisions.
Same with the youth. We're using the staff around and their counselors. And so they're really providing a lot of feedback about how they've been doing. We started doing a bunch of try to pre and post assessment scales to see, are these youth having decreases in their symptoms, as well as then we'll be looking back to see, does this have any link to later recidivism? So we'll see. But I think besides using that, the question regarding rapport, so in general, in my work with adolescents and children, it's not, you can do a lot of different fun rapport building activities and still play games and still do virtual stuff. I find it hard with younger, so preschoolers, it's a very different landscape. And throughout the pandemic, I still continued a lot of in-person with the younger clinic. Adolescents are kind of used to it. They're used to FaceTiming. But still, I think that in some situations you are missing things. And so using collateral, using other people around you. And now is the time that it's great access. We've increased access, but we really do need to look at the data. So who is this working in what situations for what populations? Because it's not the be all end all. And for training, I think it has huge implications. I was a training director over fellowship for 10 years. And so this cohort who's really only done, and you mentioned, I'd love to hear more about your experience of having a fellowship be 100% virtual.
Yeah.
That to me it's really hard to learn how to get on the floor and play with the kid and interact when it's only been virtual. So it's a different skill set. So depending on, I think we'll still remain and do a lot of telemedicine, but we're still going to have it in person. So to not have practiced that skill set will have some training implications. How was your reflection on doing a fellowship?
Yeah.
So for the audience, a forensic fellowship is 1 year.
That's right. It was 1 year. I went to a place that was not my home institution where I did my general residency. So it's moving across the country. And it's an interesting experience to do it largely virtual. In some ways, you feel more isolated from your cohort of trainees and your training directors. And so that way, I think, it certainly made it difficult to feel part of a large academic center, feel part of the community of that large academic center. I think there's a lot lost in terms of the ability to have water cooler discussion about your cases, especially when it comes to, as a forensic trainee, when you're trying to get input from different supervisors who might have had a similar case. And that goes probably for beyond just forensic training, but those water cooler discussions, I think, are lost. Popping into someone's office is lost. Now, we obviously had kind of scheduled supervision twice a week by phone or by video with different mentors. And so there were ways to make up for it, but I think in some ways it's still different. We have weekly case conferences where a fellow would present an active case to get feedback from the entire division. And again, when that's virtual, it's harder for different people to feel like they can speak up and give input to your case when they don't want to. Everybody's experience is on Zoom and trying to interrupt or not interrupt. So in that sense, I feel like perhaps people got maybe less feedback from others who were just kind of hearing the case for the first time. I think there are certain benefits of it. Like I could maintain contact with people at my home institution and continue to go to meetings and things outside of my fellowship very easily from a different state, which hopefully allows me to get the job that I got. But there's also benefits, I think, when it comes to doing evaluations, right? So you mentioned a lot of the benefits of doing telepsychiatry in correctional facilities. As an evaluator, it's often hard to get into correctional facilities to do like a competency evaluation or a criminal responsibility evaluation. There's a lot of steps that go into allowing you to come into that setting, and like a judge or an attorney has to basically grant you permission to set foot in a correctional facility for that purpose. When things shifted virtual, some aspects of that were easier. There's some different aspects of having, access to an inmate or a prisoner to perform those evaluations. It was interesting as the year went on, right? I was there before vaccines and after vaccines. And so then after vaccines, these big bureaucratic institutions of prisons were saying, well, now we're not going to support you doing virtual, so you can come in. And so it was interesting to see how some of those decisions were made and the experience shifted when it was more hybrid virtual.
I also wanted to talk a little bit about rapport, how I established rapport with telehealth. So, with inmates, they often, like I said, they're traumatized. They're born of trauma, and it's perpetuated in jails and prisons. And there's a lot of anxiety involved. And so I recall a patient who was telling me, I was trying to work with him to ease his anxiety so that we could get through the appointment. And so I said, okay, can you visualize, your favorite place on earth? And he said, the beach on Santa Monica. And so I said, okay, go ahead and describe, everything from the sand, the feel of the sand, just go through the motions of being in the beach in your mind. And then as he did that, I searched for images of Santa Monica, and I did a screen share, and I showed him, okay, so tonight when you're feeling anxious, I want you to see, I would imagine that warm glow of the sand and the Ferris wheel in the background and what have you. And I feel like it probably helped him. And then so that's an advantage of telehealth. You can just pick and choose, what you want to show them and screen share it very easily. And it transforms them outside of the prison into that, virtual paradise. Another thing that I used to do with children, or I still do with children, if I'm having trouble connecting with the child, whether if it's ADHD, do you do this too? So like I ask them what is their favorite, Disney character, or what's their favorite show or whatever. And then I'll either show them a picture of the Marvel character, or maybe a short video of that, and that instantly captures. Did you find? Have you?
Yeah, absolutely. Or just like sharing and going to. So what music are you listening to? Oh, I'm not familiar with that artist because technically, usually I'm not. I'll be like, or give me homework, and then they will assign me somebody to listen to, and I will learn all different new rap artists. But you can just quickly go and share your screen and go to YouTube and listen to the music together for a couple of minutes. So we do things like that. We play games. There's a lot. There were so many different. I think a lot of the telemental health therapists came up with some great games even just room searches. So things that show me your favorite thing if they're in their bedroom or if they're in their house. Oh, I see something back there. What is that teddy bear? And then there's just easy ways to start to connect. A lot of times they want to see, your office, and they have questions about pictures or, other objects that you have. So I think it's pretty, kids are definitely a little bit more at ease. And there's things that you can talk about. I imagine engaging an adult in a correctional institution is a little bit harder.
Yeah. Well, I think, children can be very challenging too. And I found that, so there's also a boundary issue here, right? So you mentioned they can point out things in your background, and you need to obviously be careful about, oversharing things. You don't want pictures of your family in the background or personal things that identify too much, but maybe some sense of your style and some flair to it. It's an interesting focal point. And for me, I pick and choose my spots on this, but when I'm dealing with children, sometimes the engagement is tough and they're suspicious or nervous. I have a dog and a cat, and so I have to be careful about the boundaries here. But in some cases, I'll say, "Hey, do you like dogs or cats?" And then they say, "Yeah, I like a dog or a cat." And I bring the cat or dog on camera, and you can just sort of almost physically see like the dopamine and endorphins that are, rushing with the child. And like, okay, all of a sudden you've transformed the visit into something pleasant and nice. But again, boundaries are important. So you don't want to overshare especially with adults. With children, maybe have a little bit more margin for error on that. But
I must say I did the majority of the telehealth sessions in my office still. So that's my experience. I don't have a lot of experience seeing patients from the home as being my office.
Done some, but I try to keep it more generic.
Yeah.
Try to find a spot that doesn't reveal too much. Yeah.
Definitely. One of the things somebody had mentioned about workforce development, because we know there's never going to be enough psychiatrists, child and adolescent psychiatrists. And so I think you mentioned your fellows started enjoying a different patient population through this. And certainly we have a rotation in our fellows, child psychiatry fellows, provide DJS services. And so many of them have gone on and will work with this patient population. So that's been great. But I was wondering about the diversity aspect, because as you were describing a lot of your experience of being in a large prison. And so have you seen a diversity, since you have a company, in gender or non-binary individuals feeling more comfortable perhaps working in a correctional facility versus traditional, which is most men might want to do it, not a lot of non-binary or female individuals who choose to do that.
Let me make sure I understand your question. So are you saying like inmates that are non-binary or
No.
or
The providers. So like in your workforce development, have you noticed that it has increased the diversity of the workforce?
Oh, like meaning non-binary providers?
Yes.
I have to say I don't know that I have any.
Or female.
Female. Or just diversity.
Just diversity in general. Yeah.
I think that there is. I think most of my workforce at Orbit Health is female. I think the slight majority is female, and that may be just a reflection of psychiatry being like more female providers. Would you say that, or is that
Child for sure? I don't know what the trends are with adults.
I think the adult, at least in our residency, has been clearly dominated up until this year. But I think it's national.
Yeah, I mean, I know med students, it's like 60% women and 40% men.
Yeah, and that's a whole conversation about why that's the case. But
telepsychiatry allowing some individuals who might not have felt as safe to work in these types of institutions.
Oh yeah, that's definitely true. We have, when I was recruiting for on-site providers, safety was always an issue. And I think that females brought it up more than males, they said, and with good reason, I think. And with telepsychiatry, that's never been an issue. Inmates can still act inappropriately, but that distance is very protective, I think. So, yeah,
I still do in-person work in prison. I'm still stuck in the Stone Ages. So I still go to a prison in Raleigh for inpatient mental health care, and UNC contracts to the prison. And most of the people that do inpatient in person psychiatric care at the prison are white males almost exclusively. The nurse practitioner I work with is a female. There's a couple of females on staff within the prison kind of psychiatry department, but it's largely males. Why, I don't know. I mean, females are smarter than men and decide this is a terrible environment to be in. This isn't fun. And maybe I'll get there someday soon too. But that's just kind of anecdotally what our institution looks like.
Well, I mean, I could tell you that when I first worked in jail, I felt the presence of the weight of the stare, as I was saying, and I'm male, and so I can imagine that it'd be even worse as females, as an object of an inmate's, sexual interest, but perhaps like that could be really hard. It's probably hard anyway, as a female, just in life to deal with that, but when you're in a prison, it's probably infinitely harder.
So the hypothesis would be that women, and there may be a lot of other issues on the diversity side of why people of other races might not want it. White individuals might not want to do this kind of work. I don't know
Or
enough about it, or
we still probably haven't recruited enough,
could be.
right? So we certainly know that there's a lot of underrepresented. That there's not enough underrepresented minorities in medicine. So we got a lot of work to do.
But this kind of levels the playing field a little bit,
Yeah.
right? Because your pool of providers expands nationwide, and all they have to do is get a license in the state that the jail or prison is in, and they have access. And so there's really no excuse not to avail yourself of the complete diverse workforce, right?
It's true. That's an important piece because many individuals want to be treated by people that look like them, right? So if we're able to offer that diversity, then hopefully we might be able to have better engagement and then better outcomes.
Right. And then Spanish speaking or other languages where you have a dearth of providers you can access from far remote, far flung places.
And I don't know if there's much literature on looking at that subject, like why some people work in prisons and how well we recruit.
Yeah.
Like you said, we need data.
Yeah.
We do.
I remember hearing a person that was running the chief psychiatrist for, I think it was Lake County. It's a huge county apparently. And they had so many different ethnic populations there that they could literally schedule a client with a particular language and background, one clinic, and find a provider in one of the other areas that spoke that language.
Mm-hmm.
And match him up for the visit.
Yeah.
He was presenting at ATA some years ago.
Mhm.
I thought that was sort of a nice resource.
Yeah. Yeah, good point. I mean, I think that the larger the scale, the more resources you have, right?
Yeah.
So if you are a tiny little jail somewhere in remote, Nebraska or something, that you're not going to have that diverse, pool of resources, but telehealth allows you to have that.
Do you have any African American psychiatrists on your?
Sure. Yeah.
Okay.
Yeah.
I would imagine that's a big demand in your business.
Yeah, I mean, I think that my underrepresented folks, I think, are in high demand because most unfortunately, about I would say, I think 40% of the prison population is African American.
Right.
And then a Hispanic, I think it's something like 35%.
California.
In California, but I think there are
It's
some
not all
national
over.
trends like that too. And it's like, I think just human nature is you want to be treated by somebody who looks like you. I mean,
Yeah.
It is what it is, right? And so, yeah, unfortunately, we have a overrepresentation of certain groups in jail and prison, and we don't have the providers to match up with that. But telehealth obviously helps.
I don't think it's enough to look like the other person. I think it's a cultural like if somebody from Zambia was, they're African, but they might look like the patient. But it's more like if you're from Baltimore,
Right.
and you know somebody from Baltimore, it's almost like that. That's the cultural piece that you really want to connect with. A lot can be said with very few words, so they understand your background,
Yes.
Mexicans and so forth.
Yeah, I see that actually in my practice. Sometimes people from Baltimore wind up in jail in the rural areas, and they say, we talk about Baltimore, and something kind of like toys, right? Oh,
Right,
talk about,
right.
yeah, I work here, and they kind of light up that I know something about their neighborhood. And,
Some really far away place like Pittsburgh.
yeah.
They're from Pittsburgh. They understand it.
Yeah.
Right. Yeah. I mean, I think culture is can be measured in many ways. I mean, just skin tone is just one of the many ways, but it's also where you're from, what your interests are. I connected, like I said, over football, with officers.
Right.
And that's part of the culture that I like, football. And what's a little, I don't know if ironic is the word for it, but you have here 4 Caucasians talking about, racial issues. And I mean, so obviously it'd be nice to have somebody that was not Caucasian here on this panel, but it's just not represented in healthcare as much as it needs to be.
Right.
So.
We're working on that where we are, University of Maryland. And it's difficult to make the recruitment. I mean, it's something that we push constantly, but it's very difficult.
Just wanted to check in with Michelle to see if there's any additional questions or do you have thoughts?
Well, in the chat, we just have some compliment for the panelists, just commenting that it's a great session and good tips. And they said that they do a large amount of infectious disease via telehealth in prison. So we've got folks on the Zoom who appreciate everything that you're sharing. I think we just have like maybe 2 minutes before we got to wrap up. So if there's any final thoughts or any final questions from the audience, this would be a great time for us to transition and wrap up our session today.
Yeah, I know that y'all were talking about telepsychiatry, but are there in your programs or elsewhere any like telebehavioral health into the system with like social workers, mental health counselors, things like that are being utilized at this time? Because I think the pools are much bigger when we're talking about diversity and things like that. So are those disciplines being used as well?
Oh,
So let's
absolutely.
repeat the question real quick. So the question was, we've been talking a lot about telepsychiatry, but is there any thought on the pools of other disciplines like social workers, psychologists, MFTs?
So yes, very much so. At University of Maryland, our outpatient clinics, our therapists are doing telehealth, and that consists of licensed social workers, counselors, marriage family therapists. So we have the full gamut. Definitely peer support and community health workers are also being utilized in the telecapacity as well.
Yeah, we actually have a chance to apply for some grant funding for some of the jails we're working with. And one of the jails in a really small county, they have such workforce issues that they asked that we put in money to do our counseling through telemedicine. Because they felt like we could recruit better in Baltimore than they could there. They also had space issues where their medical clinics probably like the size of a closet, and to have a social worker in there. So we are looking into that. We are doing a lot of peer-based interventions by telemedicine as well.
I agree that, so prior to the pandemic, so psychiatrists were in really short supply, and they still are. But I think post-pandemic, as our mental health issues are growing, the therapy needs are outpacing the supply, and making social work, clinical social workers, MFTs, and psychologists, and the therapy that they can provide becomes much more in demand. And so the telehealth programs were skewed towards psychiatry, but now I think that they're much more inclusive of other disciplines. Are we out of time?
I think we are. I appreciate everybody just staying on time today. I really want to thank our speakers today for this robust conversation and for making it really easy to moderate this in-person session virtually. So appreciate you very much for that. Everybody who attended, please make sure that you fill out your session evaluation for this session. And after this, we're going into a 15-minute break following, and then the closing keynote, Telehealth Policy in 2022 and Beyond, and then concluding our day with the Matrix Poster and Challenge Awards. So enjoy the rest of the Matrix conference and appreciate you for joining. And thanks again to all these wonderful panelists.
Thank you very much for honoring